Hello, class, and welcome to your CPR class, HE 110. This is a one-credit course, otherwise known as Basic Cardiac Life Support. This class is primarily geared for the healthcare provider or the healthcare provider student who will be going into clinical practice. However, if you are not in the healthcare related field, you also stand to benefit from this class as well. My email is swhitlock@qcc.cuny.edu. Please refer to your Blackboard learning outline for further developments, notes, videos, and announcements regarding this course. So let's give a little background as to what we're trying to accomplish here. When we're talking about CPR, we're talking about cardiopulmonary resuscitation, giving the immediate care to somebody who has suffered an out-of-hospital cardiac arrest, or sometimes referred to as sudden cardiac death. This is not a person who has had long-term illness or somebody who has been involved in a major accident. This is somebody who has otherwise been living a normal, productive life, and for various reasons just suddenly collapses and ceases to have a heartbeat and ceases to have breathing. By medical standards, they are considered clinically dead. However, as we will talk about in the next few minutes, in the next few frames, clinical death does not equal biological death, and it does not equal brain death. If we can intervene and take over somebody's breathing and heart rate, within a very quick amount of time, person stands a good chance of surviving. But just to go over some of these statistics regarding out-of-hospital cardiac arrest, from this point on, we'll just refer to this as cardiac arrest instead of sudden cardiac death. Currently, 9 in 10 people who have cardiac arrest outside of the hospital die. About 350,000 cardiac arrests happen outside of hospitals each year. And unfortunately, half of the people who experience cardiac arrest at home don't get the help they need from bystanders before an ambulance arrives. If you live in New York City, the average response time of an EMS ambulance for a priority cardiac arrest is about 8 minutes. But we'll learn that when somebody goes into cardiac arrest, irreversible brain damage occurs in only 4 to 6 minutes. That's why bystander CPR is such an important component of survival from out-of-hospital cardiac arrest. Because approximately 70 to 90% of individuals with OHCA, out-of-hospital cardiac arrest, die before reaching the hospital. But the good news is that early, high-quality CPR, including compressions only, or the use of rescue breathing, and use of, more importantly, an automated external defibrillator immediately following cardiac arrest, can reduce morbidity and save lives. And these are all statistics from the Center for Disease Control. That if the heart itself has a narrowed coronary artery, at rest it may be fine, but when you start increasing the demand for oxygen, something's got to give. The muscle becomes irritated, it becomes hypoxic, and the individual will start feeling pain. This pain will be temporary though. Once you relieve the burden of the heart, relieve the oxygen demand, the pain generally goes away and no permanent damage has occurred. However, this is still somebody who has a high risk of developing a full-blown heart attack and has a future risk of going into what we call sudden cardiac death or cardiac arrest. Now, a true heart attack occurs when there's an absolute complete blockage in one of these arteries that feeds the heart muscle, these coronary arteries. And the reason this happens is because as this artery is becoming diseased and plugged up with these fatty deposits, it becomes weakened, and the inside wall of the artery can become weak and tear, and a blood clot can form. And once that blood clot becomes big enough, it completely blocks off the entire artery, compromising all blood flow downstream to where that heart needs to be fed. That is called a cholesterol plaque. And once that occurs, the progress of that heart dying begins. It doesn't necessarily happen all at once. It's a progress. Complete death of that heart muscle will occur within 6 to 12 hours if that blood flow is not restored. And that's the level of the hospital to determine which is the best way they can restore blood flow. One of the most serious complications of that heart attack is sudden cardiac arrest, sudden cardiac death. However, most times heart attacks, or what we call myocardial infarctions, result in pain to the chest. Now, chest pain can be described in a number of different ways. Some people describe it as pressure, some people describe it as sharp pain, some people just describe it as an uncomfortable sensation. However, you want to look at all the risk factors involved, such as high blood pressure, uncontrolled diabetes, advanced age, sedentary lifestyle, poor cholesterol profile, poor eating habits, nicotine smoking. Put those all together with someone who in this picture is clutching his chest in pain, and you have a pretty good idea that this person is having a severe, true heart attack. And there are other signs and symptoms that can occur with heart attacks as well. For one thing, you can have discomfort or tingling in the arms, back, neck, shoulder, or jaw. Sometimes people don't even have chest pain. They'll complain of pain in the shoulder. They'll complain of pain in the jaw. Sometimes they'll mistake their pain for being a muscle pull or a dental issue. And that's something called referred pain that occurs because there's a mix-up in signals from the sensory nerves from one area to the other. Sudden dizziness will occur if the heart is not beating properly due to compromise in blood flow. Quite often people with certain types of heart attacks think they're just having heartburn or indigestion. In women, sometimes they'll complain of just a cold sweat and no other symptoms. In your elderly, just unusual tiredness and fatigue for no reason. Nausea and vomiting is very common with heart attacks, especially vomiting without a preceding sense of nausea. Shortness of breath also usually occurs with chest pain when you think about it, because there is a demand for oxygen. So just to recap, what occurs during the process of an acute coronary syndrome is, first of all, you understand that you need an open patent coronary artery to feed oxygenated blood to the heart muscle or the myocardium at all times. Over the course of many years, and usually in this country beginning all the way back to childhood, a fatty plaque builds up in the artery. And at a certain point, when enough plaque builds up and that artery is about 70% or so blocked up, it becomes much harder for blood to get through the artery. At rest, this person may feel no problems at all, but when they exert themselves and they increase their demand for oxygen to the heart muscle and have a decreased ability to deliver oxygen to the heart muscle, they experience a condition called angina. Chest pain, shortness of breath, maybe even some radiating pain that feels like a heart attack, however, does not result in any permanent damage to the heart itself. If blood flow is reestablished, if the oxygen demand is reduced, if the person is at rest, if they cease their physical activity, or if they take a medication called nitroglycerin, which helps open up these blood vessels, blood flow is usually restored and the pain subsides. A true heart attack, which is medically called a myocardial infarction, occurs when a weakness in this artery results in a tearing of the inside and a formation of a blood clot, which completely blocks off the flow of oxygen to the heart. And as such, if no oxygen gets to that heart muscle, the heart cells or what's called myocytes, start to die off. First, they become ischemic, irritable because of lack of oxygen, just like when you fall asleep on your arm and it becomes numb. Then it goes through a process of injury where the heart cells start breaking down. However, they can still be saved if oxygen flow is reestablished until the point of infarct, where the heart muscle cells actually die off. And as I said before, this is a process that occurs. To really help understand who's at risk for having a heart attack or myocardial infarction, you have to have a little bit of an understanding of the disease or the risk factors that go hand in hand with heart disease. Number one preventable risk factor of heart disease is tobacco smoking. Cigarette smoking does a number of things. It elevates blood pressure. It causes constriction of blood vessels. It makes the blood vessels more prone to clotting, just to name a few things. Certain types of infections may make a person prone to myocardial infarction, but these are more or less common than the acquired risk factors. Now, funny, very, very mild to moderate alcohol drinking actually has a protective effect over the cardiovascular system, but alcohol in excess can also lead to heart attacks and heart disease. You also have to think about your family history. Somebody who has a father that died of a myocardial infarction at 40 years old and a brother at 38 years old who also had a couple of MIs is probably at a very high risk for having a myocardial infarction themselves. Unhealthy food that's filled with saturated fats and trans fats have been long known to be very prone to contributing to cardiac disease. Obesity, meaning body mass index of over 30%. Sedentary lifestyle, somebody who does not exercise. Unfortunately, the body was meant for strenuous work. Hasn't really evolved beyond that over the days. Advancing age is always a risk factor for heart disease. It's just an unfortunate fact of life that the older we get, the less efficiently our bodies work. And then finally, a high stress lifestyle can also result in increase in the incidence of heart disease. So now that we've taken some time to explain the incidence of heart disease and how heart attacks, myocardial infarctions, actually work and who's at risk, let's talk about the most severe complication of myocardial infarctions or acute coronary syndrome, and that is sudden cardiac arrest or sudden cardiac death. Whatever you want to call it, the end result is the same thing. When somebody's heart stops beating and they stop breathing, they are considered clinically dead. If intervention does not take place quickly enough, that person will die. So cardiac arrest is when the heart actually stops beating. It is not the same as a heart attack. When the heart stops beating, oxygenated blood does not get to the brain, it does not get to the organs. And if you see in this slide that when the brain goes about 4 to 6 minutes without oxygen, then brain damage starts occurring. And brain damage is irreversible. Now, if it's just a few brain cells, person may make a very good recovery. If it goes in the later minutes, more towards the 6 to 8 minute range, morbidity is probably going to be increased. And after 10 minutes of no blood pumping to the brain, biological death is imminent and probably death of the individual as well. Even if you are able to resuscitate an individual after 10 minutes, the brain damage is probably going to be so severe that they will likely live in a vegetative state on a respirator for their remaining days. That's why early intervention is so key. The sooner we begin, the sooner we act, the better chances of survival this individual has. That's why the American Heart Association has this algorithm or this analogy of what's called a chain of survival. We're going to look at the bottom half of this slide for out-of-hospital cardiac arrest. And what are the components of this chain of survival? Well, first off is activation of the emergency response system. But even before that, I would say a big part of that first link would be to recognize the risk factors for heart disease, to recognize the signs and symptoms of a heart attack, and to recognize a sudden cardiac arrest, which we will talk about in a few moments. But then, most importantly, activating the emergency response system. Now, that may mean calling 911. That may mean calling your emergency medical officer if you're working in a huge industrial complex. Take the gym building at Queensboro, for example. If somebody has a medical emergency in the gym, calling 911 wouldn't necessarily be the most appropriate thing because the ambulance would end up at the front gate of the campus and not know where it was going. The more appropriate thing to do was to pick up any of those red phones that are in the hallway, call security, and have them respond and get the process rolling and be a much more efficient means of getting help. So the next link in that chain is high quality CPR, cardiopulmonary resuscitation. The heart is not beating on its own. So we're going to physically take our hands and push on the chest so we can move the blood through the body and take over the function of the heart, which is not doing it on its own. Another component of CPR, which is dubbed in a little bit of controversy, is giving rescue breathing, trying to get oxygen into those lungs to be carried by the blood. Now, in the first few minutes of cardiac arrest, there is oxygen in the blood. The most important thing is that it has to be moved around. So there is some call for not doing rescue breathing or rescue breaths in the first few minutes of CPR. However, if we do rescue breaths, it's just that much better. But the most important intervention in sudden cardiac arrest or out of hospital cardiac arrest, sudden death, is defibrillation. The use of a machine that gives a shock to the heart, an electrical shock, to help try to reset, for lack of a better word, or reboot the heart back to its normal activity. Because we're going to learn in a few slides that when the heart stops beating, it doesn't cease all activity together. The heart is an intricate machine run on electrical wiring system, and usually the first few minutes it's that electrical system that's in all disarray. The early application of defibrillation is the immediate answer to that problem. And then after that, advanced resuscitation with medications, advanced breathing tubes, machines, post-cardiac arrest care, trying to limit the amount of end organ damage that occurs, and then finally recovery are all the steps that occur at the advanced stages. But for the purposes of this course, we are going to be responsible for the first three chains in that link. Early activation of the emergency response system, I should say, high quality CPR, and defibrillation. So just for nomenclature purposes, we have to define age parameters when we talk about proper CPR sequences. Although there's a big disparity in development from an infant to an adult, for the purpose of making it easier, we're going to define infants as less than 1 year old, excluding newborns. Newborn or neonatal resuscitation is a whole course in and of itself. So infants are less than 1 year old. Children are considered 1 year until the onset of puberty, defined as the development of underarm hair in males, breast buds in females. Obviously, you would use your best discretion. Adult would be considered anyone who has reached puberty on. And again, you use your best clinical judgment when you're deciding which algorithm to follow. So when deciding to give help, when deciding to respond and administer CPR, the first thing you have to consider before anything else is checking the scene for safety. If you are not safe, then you cannot do any good for anybody, whether it be a family member, a coworker, best friend, or bystander who's in trouble. So obviously this scene, this slide shows probably the worst case disaster scenario that could occur. Even after 25 years of being in emergency services, I would not walk anywhere near the scene unless I was adequately prepared, which I would not be if I was on my own time. So think about stopping, resisting that urge to be a hero. Look both ways before crossing the street. Make sure you're not putting yourself in any situation where you're exposed to any chemicals or any electrical current or any wild animals. Take a deep breath. Take a good 10 seconds to gather yourself and make sure that scene is safe. Then once you have secured your safety, once you're sure that everything is adequate, you're going to go up to the victim or the individual and you're going to simply check for responsiveness if you don't know what's happened. They could be just sleeping on the street for all you know. They may have some type of medical emergency where they're just not responding. But of course, if they're in cardiac arrest, they're not going to respond at all. So how would you check for responsiveness? Very simply, you would tap the individual on the shoulders and say, "Hello, hello, are you okay? Can you hear me?" If the person shows obvious signs of life, if they start swatting your hand away, or if they just say, "Yeah, I'm okay, leave me alone," then you obviously know that they don't need CPR. If there is no response and no obvious signs of life, like swatting your hand away, movement, spontaneous breathing, then you're going to need to make the decision to call 911 or call your emergency response system, whatever the case may be. Most of us have cell phones on our person. Take out your cell phone and call 911 or whatever the local emergency response number is. To this day, there's still not 100% community that have a 911 service. There are some towns and townships where you need to dial a 7-digit number to get an emergency response. And just remember that not every place in the country has adequate cell phone service. So you may need to go and call 911 on a dedicated landline yourself. Obviously, if you have somebody with you, send them to call 911 or help as well. What if you're all by yourself and you stumble upon somebody who you don't know what's happened, but you've checked for responsiveness and there's no response? What would you do? Well, that's tricky. That depends on if this person is an adult or child or infant. If this person is adult and you determine they're unresponsive and you don't have access to immediate 911, leave the scene, go get help, and come back. And we'll talk about the reason for that in a few slides. If it is a child or infant, you want to continue your assessment and do about 2 minutes of care before leaving and calling for help. And we'll talk about the reasons for that as well. So as far as calling 911, the biggest piece of advice to give you is to do your best to stay calm. If you've ever called 911, you'll probably notice that a number of questions are going to be asked. Where are you? What's the patient's name? How old is this person? Are they awake and breathing? What's the emergency? It may seem like they're asking nonsensical questions that are just wasting time. Believe me, there is a reason for them to ask all these questions. Please answer the questions as they're being asked. In New York City, for example, at any given time, any given day, there's about 4,000 calls for EMS and 911 every single day. And that's just on an average day. The call volume can skyrocket up to 7,000 during times of crisis. There's only about maybe a good 250 ambulances in all of the 5 boroughs at any given time of the day to handle all of these calls. in the 911 system. Quite often, there's going to be a much greater need or demand for ambulances than ambulances available. So the 911 system has to use what's called a triage system. They have to ask these questions, screen them, and try to get the appropriate ambulance to those who need it the most. Somebody who broke their ankle and can't get up and walk off a baseball field probably needs an ambulance as well to prevent further injury for their ankle. But that's a lot lower priority than someone who is not awake and not breathing. So in New York City, for example, when you call 911, your call goes to a police operator. That police operator verifies the call, verifies the information. Once it's determined that it's medical in nature, routes it over by conference call to the EMS department in the fire department. That EMT call receiving operator will now take that call, re-verify the location, and ask a number of questions. Is the patient awake and breathing? How old is the patient? And while they're doing this, they're typing in information and sending it to another individual, the dispatcher, who via computer is already looking for the nearest available ambulance to send out there. So the call receiving operator asking questions and also giving first aid directions does not delay the response of the ambulance. All these things occur simultaneously. So keep calm and speak clearly. Do not hang up until the EMS operator tells you to. So as we said before, once you determine his unresponsiveness, get help as quickly as possible, especially for the adult victim. Because as far as CPR goes, what's even more important than compressions on the chest or rescue breathing is getting this electrical device over to that victim as quickly as possible. Defibrillation, or the use of an automatic external defibrillator, or AED, is the definitive treatment, the level 1 proven treatment for out-of-hospital cardiac arrest. The longer the delay in getting the AED or the defibrillator to the victim, the less chances they have of making a good survival. So now, after we have determined unresponsiveness, called 911 or send somebody for help, we want to do what's called an initial check. We're going to check for breathing and for a pulse. So we're going to check for breathing by pulling the head back, by putting one hand on the forehead, two fingers on the chin, pulling the head back, and we're going to look, listen, and feel. We're going to look to see if the chest rises. We're going to listen for any breathing noises. We're going to feel for air on our cheek. We're going to feel for a pulse. A pulse is a representation of the heartbeat anywhere where an artery comes close to the surface of the body. The easiest and most practical pulse to check for is called the carotid pulse, which is found in the neck between the Adam's apple and the muscle in the neck called the sternocleidomastoid. We're going to do this for no more than 10 seconds. 10 seconds. Now, if while doing that initial check, person has obvious breathing, if they're moaning, groaning, talking to you, then you know there are obvious signs of life. We don't necessarily need to go on and do CPR at that point. But if after 10 seconds you don't absolutely beyond the shadow of a doubt feel a pulse or see signs of life, we're going to start intervening with CPR. And I tell you, pulse checks are very difficult. Even well-trained ER physicians sometimes have a hard time assessing a pulse on a patient for a number of reasons. But the more time we take trying to determine if a pulse is there, the more time that brain is going to go without oxygen because of our indecisiveness. So no more than 10 seconds. If you do not absolutely feel a pulse, we're going to begin CPR. If there is definitely a pulse and breathing, well, that's great. But now what are we going to do? Well, we want to put this person into what we call the recovery position. We want to turn them over onto their side. We want to put one hand over, one leg over, pull them by the shoulder and the hip in what's called the high arm in neck position, Haynes position. This is called the recovery position. Number of reasons for this. One, it helps prevent them from choking if they start vomiting. It helps drain the mouth of any secretions. It helps facilitate their breathing, and it keeps their airway open. And at this point, if you haven't sent anybody to get help at this point, you can go and do so and just keep an eye on that victim. If, however, you don't obviously get a pulse or any signs of life, and this person pretty much is unresponsive and, for lack of a better term, appears dead, then you're going to begin CPR compressions. You're going to line up your arms, put the heel of your hand on the lower half of the sternum, lock out your elbows, put your shoulders over your elbows over your wrists, and you're going to compress the chest in the adult about 2 to 2.5 inches rhythmically. And what you're doing is you're physically moving the blood around the body that wasn't being moved at all and getting oxygen to the brain, which wasn't happening before. Now, depending on whether you're doing an adult, child, or infant, and you should know that there are demonstration videos on your Blackboard menu which you must look at in order to pass this class. If you look at your hand placement in the adult, 2 hands go on the lower half of the sternum. The heel of your hand goes on the lower half of the sternum of the breastbone. The other hand is going to pull the fingers back. You're going to lock out the elbows, shoulders over elbows, elbows over wrists, so that you're making a right angle, and you push straight down and recoil up. Straight down and recoil up. Now remember, adult is from puberty on. When you're talking anybody who's from 1 to the onset of puberty, you're talking about a child. For a child, its technique is relatively similar, except that you would use either 1 or 2 hands depending on the size of the child. In an infant, it's a little bit different. Infant is defined as less than 1 year old. For the infant, if there's one rescuer, you're only going to compress with 2 fingers right between the nipple line. Actually, about a finger's width below the nipple line. If you have 2 rescuers, you're going to use what's called a 2-thumb encircling hand technique, which is demonstrated on your video. In the adult, you want to compress about 2 to 2.4 inches. That's a guideline. You just do your best. In the child and infant, the textbook answer is 1/3 the depth of the chest, or approximately 2 inches. And the rate remains the same. You want to compress at a rate of about 100 to 120 compressions per minute. The average adult heart rate for somebody who's healthy and not ill is usually about 60 to 80 beats per minute. However, even the best performed CPR only restores about 30% of normal circulation. So the technique really has to be pristine in order for this person to make a proper recovery. So here's a diagram of the proper hand placement for a child. As you can see on the left, the rescuer is using 1 hand to compress the sternum, 1 hand to hold the airway open. On the right side, you probably have a bigger child, so the rescue, or a smaller rescuer, so they're using 2 hands, which is just as appropriate. For the infant, if you look at the hand placement, 1 rescuer is going to use 2 fingers on the bottom half of the breastbone and compress about 1/3 the depth of the chest. If you have 2 rescuers, 1 rescuer is going to wrap their hands around the infant's torso and use 2 thumbs on the lower half of the sternum to compress the chest the same distance. And the second rescuer will be taking over rescue breathing, which we'll go over later. So you may have seen in the movies or on TV or any other type of media somebody giving mouth-to-mouth resuscitation or doing CPR where compressions were interposed with mouth-to-mouth rescue breaths. And can tell you, you probably already know there's a number of reasons why you probably don't want to do mouth-to-mouth on an individual. But just to give you an idea of how mouth-to-mouth breathing works, when you breathe in oxygen, the room air that you're breathing is 21% oxygen. Most of the room air that you're breathing is actually nitrogen. A little bit of carbon dioxide, a little bit of water vapor. Out of that 21% oxygen that you breathe in, you only absorb about 5% of that. So each time you exhale, you're exhaling 16% oxygen. Now look at the diagram on the left. This person who's in cardiac arrest is not actively breathing on their own. They're not expanding their chest. They're not pulling air into the body. So the theory behind giving rescue breaths is to push that 16% oxygen in your exhaled air into the lungs to be absorbed through the lungs into the bloodstream and to be carried to the parts of the body. And on the right side, you're just seeing the same technique modified for an infant. Instead of mouth to mouth, it's mouth to nose and mouth. So they're basically covering the infant's nose and mouth with their mouth. Now, of course, you may want to consider doing this if, God forbid, it's a loved one or a close person to you that's in cardiac arrest. Hopefully, knock on wood, that's never the case. But to also let you know that this is a little bit controversial. There's been a lot of recent evidence to suggest that positive pressure ventilation, or rescue breathing, so to speak, is not necessary in the first few minutes of cardiac arrest. In the first few minutes of cardiac arrest, as I've said, there is oxygen already in the blood. It's a matter of getting that oxygen to where it needs to go. Most importantly, the brain, for that person to make a good recovery. That's why the CPR compressions are much, much more important than ventilations. However, at some point, if you do have to give ventilations, there are many different barrier devices to provide the same effect as mouth-to-mouth ventilation. So instead of this person pulling air into their lungs, which is called negative pressure, we're providing positive pressure, pushing air into the lungs. What you see on the left is a device called a bag valve mask resuscitator, preferably used by two rescuers, one at the head holding a tight seal and one squeezing the bag. And used properly, this can be hooked up to oxygen, and this can force air into the lungs, oxygen so to speak, to be picked up by the blood and carried to the brain. On the right side, you have a rescuer using what's called a pocket face mask. The pocket mask allows this rescuer to give mouth-to-mouth resuscitations without making direct contact to this person's face. It has a filter and a one-way valve, so when the victim exhales, the air is diverted away from the rescuer. Both these devices are very effective means for delivering positive pressure ventilations. So when we do full CPR and we interpose rescue breathing with compressions, we do it in cycles. So if you see here, when you have one rescuer by yourself, you want to, after 30 compressions, stop and give 2 breaths, whether it be by mouth to mask, BVM, or whatever device you have available to you. BVM is not really preferred if you have only one rescuer, because it's very difficult to hold a proper seal and ventilate appropriately with a bag valve mask resuscitator. A pocket mask would be much more preferred if you were a lone rescuer. So if you see adult, child, and infant, if you're the single rescuer, then your cycles of compressions to breaths are all the same. 30 compressions to 2 breaths. Child, 30 compressions to 2 breaths. Infant, 30 compressions to 2 breaths. When you're talking about 2 or more rescuers, things change a little bit. So with the adult, it's still 30 compressions to 2 breaths. And after about 5 cycles, you want to switch roles. You don't want one person doing compressions for any more than 2 minutes in a row, because they're going to get tired. Even if they don't feel like they're getting tired, they're going to get tired. The efficacy of the compressions is going to diminish, and the chances of successful outcome are going to diminish. So always switch roles after about 5 cycles. In the child, we're going to change things up a little bit. We're going to do 15 compressions to 2 breaths. 15 to 2. So if you're going to cut the number of compressions by half, you're going to double the amount of cycles to keep it within that 2-minute range. So switch rescuers after 2 minutes or about 10 cycles of 15 compressions to 2 breaths. And the same thing with the infant. 15 compressions to 2 breaths, switching rescuers after 2 minutes or about 10 cycles. You want to use the AED, the automated external defibrillator, as soon as it is available. Speaking of the AED, or defibrillation, defibrillation is the means of administering an electrical shock through the heart to try to, I don't want to say the word jumpstart, it's not really an accurate analogy, but for lack of a better term, jumpstart the heart back into working again. There are a number of different types of AEDs on the market. American Heart Association or Queensborough does not endorse any type of brand over another, because they all work on pretty much the same principle. You have to recognize the cardiac arrest, you have to make the decision to respond, you need to administer CPR until the AED is available, and once the AED is available, you need to put it on and follow the prompts. Most AEDs tell you what to do and how to do it. They're very, very user-friendly. There have been studies comparing 6th graders to seasoned paramedics in the use of the AEDs, and they found that a 6th grader can be just as effective as a seasoned paramedic. Talk about a blow to my ego. So let's try to understand a little bit about how an AED works. And to understand that, we're going to try to talk a little bit about the physiology of the conduction system of the heart. It's not very complicated, because as I said before, when the heart stops beating initially, there's still some activity in it. So what allows the heart to beat at a certain rate every minute, every day, every hour of your life? What allows the heart to beat in a synchronized fashion, with the upper chambers beating first, the lower chambers beating next? Well, the heart is run by a little area in the right upper atrium called the sinus node, or what's called the sinoatrial node. The sinoatrial node is considered the normal pacemaker of the heart. It's an area of specialized tissues which will send out a jolt of electricity, yes, electricity, which will lead to something called depolarization. Depolarization is a term that leads to the activity that leads to the muscle contraction. So that electrical current is spread through the atria, and it depolarizes both atria, and then that electric current is rerouted to this area over here called the atrioventricular node, where it's paused for a split second. That split second pause allows the atria to contract and empty their contents into the ventricles. Then from there, the electrical current is split to the left and right tracts in this big muscular wall between the ventricles called the ventricular septum, called the bundle branches. And then the electrical current goes through each and every part of the heart and depolarizes the ventricles. So first the atria contract, then the ventricles. The atria and the ventricles. Boom, 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 boom. And that electrical activity can be represented on the bottom of the picture here, where you see a wave of electrical activity called the normal sinus rhythm. The first bump you see is called the P wave, which represents depolarization in the atria. Then this tight spike that you see next is called the QRS complex, which coincides with ventricular depolarization. Then that last little bump called the T wave represents everything resetting itself. And that's what happens during nice normal heartbeat. But when the heart goes into sudden cardiac arrest, usually due to a complication of a myocardial infarction, what's happening? All these other cells that are lacking oxygen and becoming irritable and unstable start firing at random. One part fires, the next part fires, the next part fires, so there's no coordinated electrical activity whatsoever. So in this case, the ventricles do not pump, they quiver. And that quivering does not allow the heart to pump out any blood flow. So the victim becomes pulseless. No oxygen gets to the brain, they pass out. They are in cardiac arrest. They are considered clinically dead, for lack of a better term. The purpose of the AED is to deliver a counter shock to kind of knock out that crazy electrical activity in the hopes that the normal sinus rhythm will start resetting itself and allow for a normal sinus rhythm again. Until the advanced care, the paramedics or the code team can get there and stabilize the patient with their drugs and their other interventions as well. So once the AED becomes available, it should be applied immediately. Really the hardest part about these machines is just remembering to turn them on. Once you turn the power on, the machine tells you everything that you're supposed to do by itself. So as it says here, there's usually enough oxygen in the bloodstream to postpone ventilations for a few minutes while chest compressions are being performed. The AED should be applied while chest compressions are being performed. It works by connecting two electrodes to the machine. One electrode goes under the right collarbone, the other electrode goes on the left side of the rib cage. And once those electrodes are on, the AED will tell you to plug in the electrodes and it will read the activity going on in that person's heart. Now, if you are by yourself with an AED, the question is what should be done first, CPR or application of the AED? And the answer is application of the AED. That is the definitive treatment for cardiac arrest. If you have one or more rescuers available, then it would make sense that one person would continue CPR while the next person would apply the AED and set that up. So first things first is we want to verify that there is no pulse, no obvious signs of life, making sure that we're not accidentally going to defibrillate somebody who is having a pulse, although the AEDs are very good at assessing that. And if this person has a pulse that you may not be able to detect, this AED will not charge up. It will not allow itself to deliver a shock. But the most important thing is once that AED determines that a shock is appropriate, your job is to make sure nobody else is touching that individual. You don't want to inadvertently shock your partner or a family member, because this has happened and it does happen from time to time. So while that AED is analyzing and charging up, you want to scan up and down, head to toe on that victim, making sure I'm clear, you're clear, everybody's clear. And before pressing that button, yell out at the top of your lungs, "Clear!" This way, scare everybody away from that patient, because when you press that shock button, the patient is going to jolt up and he is going to show muscle contractions. So you press that button, and once that button is pressed, immediately go back into CPR. Do not waste time trying to check for a pulse to see if it worked or not. Even if it works on the first shock, chances are pulse will not resume for a good 45 to 60 seconds. You've just stunned that heart. It's going to take a few moments for it to reset itself and for blood to get back into that muscle to do what it's got to do. So you want to take over with CPR, preferably with the next person doing compressions and rescue breathing, and continue patient care following the AED prompts. The AED will tell you after every 2 minutes, because this has a built-in timer in it, to stop compressions, stop CPR, so it will analyze. If the patient, if this AED says no shock advised, then you would reassess the patient. You would try checking for a pulse, looking for signs of life. If no pulse, no signs of life, you still continue CPR. The AED may have not just found a shockable rhythm. If there are signs of life, you stop CPR and then you continue your assessment from there. You have to watch for some very important safety considerations. For example, if the patient is lying in water, say they collapsed in a gym, in the shower, or in the fitness center, and they're lying in a pool of water, take them out of the water, dry them off before applying the AED. If they're on a metal grating for whatever reason, get them off the metal grating. Make sure that that patient isn't reaching over and touching anybody while they're being shocked. If the patient's wearing a nitroglycerin patch, nitroglycerin is a medication that helps keep the coronary arteries open. Not very common these days, but it's something that needs to be looked for. Then you need to, with a gloved hand, remove that patch. No, they will not explode from the nitroglycerin, but if delivering that shock, some of that nitroglycerin splatters and gets on your skin, it can cause dizziness, headache, even loss of consciousness. So we don't want that to happen. Now, something that's relatively new in the American Heart Association CPR guidelines is introduction to the recognition and treatment of opioid overdoses. When I talk about opioids, I'm talking about narcotic medications, either prescription or illicit substances. Narcotics are drugs that are meant to alleviate pain and have a very, very prominent role in medical treatment. However, they're also very abused in this country, leading to a number of deaths and overdoses. Most narcotic overdoses are, these days, not as a result of injectable heroin, but actually as a result of misused opiate prescriptions. And these misused prescriptions often lead to illicit use of heroin and fentanyl-laced heroin, which can ultimately lead to death. So, some signs of an opioid overdose, as you see here, are things like blue lips or nails, dizziness and confusion, can't be woken up, choking, gurgling, or snoring sounds, slow, weak, or no breathing, drowsiness, or difficulty staying awake. When you have an individual who's unresponsive, barely breathing, or only gasping in their breaths, they're very likely going to die of this overdose if intervention is not implemented quickly. That's why there's been a big public health initiative to train and provide this medication called Narcan, otherwise known as naloxone, which is a drug that's been used in EMS for years, which blocks the effect of opiates and in itself tends to resuscitate the individual who has overdosed on these opiates. A couple of caveats when using this medication. If you have someone who's overdosed on heroin or fentanyl or any other illicit or licit drug and you wake them up with Narcan, and there is a video in your lesson folder as to how to properly administer Narcan, they're not going to be your friend. They're not going to say, thank you for saving my life. They're going to be very angry and bitter at you because you've taken away their high. May even find yourself on the tail end of some aggression. So be very, very careful and wary when using this medication. It is not to get somebody unhigh. If a person is awake and talking and breathing on their own, do not come anywhere near them with the Narcan. All right, this is only for life-threatening interventions. It's very important intervention for family members who know they have a heroin or opiate addict, someone with opiate use disorder in their house, and training in the use of it is very important to save people's lives. We get it. Just be very careful with this. And it's very simple to administer. You open the package, you do not give it any primer squeezes like you would with a bottle of Afrin. You squirt one shot into each nostril. It gets absorbed through the nasal mucosa, it gets into the bloodstream, and then it has its effect. Please make sure that you watch the video in your lesson folders as far as this goes. So, just to recap what we're going to do when we're going to make the decision to apply CPR. And again, this is the healthcare provider algorithm. As it says here, first, verify scene safety. Check for responsiveness by tapping the shoulder, saying, "Are you okay? Are you okay?" Shout for nearby help. Get your cell phone, activate the emergency response system, go pick up the red phone or whatever you need to do to get the emergency response system available to you. Get an AED as quickly as possible, or send someone else to do it. Assess the patient. Look for breathing. Are they breathing or only gasping? Do they have a pulse? Is a pulse definitely felt within 10 seconds? If it's normal, breathing and pulse are felt, keep them in that recovery position and monitor until responders arrive. If they're not breathing normally, but you do feel a pulse, then you want to provide rescue breathing at 1 breath every 6 seconds for the adult, or 1 every 3 to 5 in the child or infant. Reassessing the pulse every 2 minutes. Remember, there could be a number of reasons why somebody has a pulse but is not breathing on their own. Could be an opiate overdose, it could be a stroke, could be head trauma, could be a drowning victim, could be smoke inhalation. But again, that's only if you know there is definitely a pulse felt. Now, if you go to the bottom of the picture, is no breathing or only intermittent gasps and no pulse felt and no obvious signs of life, we're going to start CPR. 30 compressions and 2 breaths using the AED as soon as it's available. Okay, once the AED arrives, you're going to apply it and check the rhythm. Does the AED recommend a shock? If so, on the left side, you're going to give 1 shock, resume CPR immediately for 2 minutes, and follow the AED prompts until advanced providers arrive. If you turn on the AED, it analyzes and it says no shock advised. Immediately resume CPR for 2 minutes and let the AED reevaluate after 2 minutes until advanced providers come along. And that's basically it. It's not very difficult. If you watch the training videos, if you look at the slides, if you follow everything to the T, you probably do very well on your written exam. If you decide to come in on day 2 and take your skills practice, it's even more important that you watch those training videos. The skills checkouts are not mandatory to get 1 credit for this course and pass this course. The skills checkouts are only mandatory if you want a certified BLS, American Heart Association card, for whatever reason. And with that, good luck in this course and good luck with your future academic endeavors. This is Stephen Whitlock.